I'm going to transition into my presentation on psychosocial care of the dying and bereaved. I took this course back in September, and it's offered twice a year through the Victoria Hospice Society. So who takes this course? As you can see, there is a large number of professions on here, and I actually haven't listed them all, but this was a course where people from all different professions came. It was really neat. What you get out of this course: it's an introduction into psychosocial care and its importance in palliative and hospice care, 5 full days of guest speakers, presentation, and workshops. And there was a pre-arranged seating plan with multidisciplines at every table, which was really neat because it was a chance to meet professionals from all walks of life. We got a brand new textbook that just came out in January, and that was mailed to us following the course, and I will put this up on 4th floor. This is a great tool, and it can be ordered on the Victoria Hospice website. There's some really great things about bereavement and doing psychosocial assessments in here. There also was a jump drive that came full of resources for additional reading, and I'll make sure that that's upstairs as well. So obviously I can't go over a 5-day course in a 20-minute presentation, so it's going to be a very compact presentation. So I'm just going to tell you sort of what we talked about each day, and then reflect back on the things that I found important. And the really neat thing about this course is a lot of it is about personal interpretation. So what I got out of this course could have been totally different than what a physician got or a social worker got. And that was what the really neat thing about this was. So on our first day, we talked about our personal relationships to work, the psychosocial perspective, an introduction to death and dying, and approaching death. So first of all, what is psychosocial care? And this definition comes directly from Victoria Hospice. It is attending to the psychological, spiritual, social, emotional, practical needs and wishes of the individual within the context of their community of family, friends, neighbors, and associations. So what it includes: human connection, planning, rituals, life review, financial, legal, and practical support, and counseling. So what it assumes is that people have strength and resources, people have their own culture, patients and families are in the driver's seat, and a team is required for care. What it does not assume is that physical needs are the greatest, we know what people want or need, or that it is our job to mask or fix the problem. And again, this came directly from the initial presentation. The main presentation on day 1 was called Psychosocial Perspective, and it was presented by Wendy Wainwright, Director of Clinical Services. She's also the co-author of this textbook, and she was just an enormous part of this course. So why the psychosocial perspective is important? It is holistic. It attends to people's experiences of their illness, symptoms, and dying. It values relationships. It acknowledges and appreciates diversity, and it attends to what is important to people over time. What does it require of us? It requires us to be self-aware, reflective, and responsible for ourselves, competent team members, skilled in our practice, and it also requires us to consider possibilities and alternative perspectives. So of course, our perspectives are largely based upon our culture and our experiences in the world, and they're all different. So we all know that working with colleagues and patients with different perspectives can be very challenging. And this was a really neat slide that she talked about. And it kind of makes you check yourself at the door and how rigid you are in your ways. So do your perspectives change when you hear someone else's point of view? Do you see this difference as an opportunity to learn and grow? Or do you see them as a problem, something to tolerate, and something that makes your job harder? Psychosocial, that's a very big, scary word for a lot of people. It's particularly hard in an acute care setting with limited time to feel you can adequately assess someone's emotional needs. And care providers are often faced with many barriers and may shy away from trying to do these psychosocial assessments. Some of the barriers, we're afraid of unleashing strong emotions. We don't want to upset our patients. Having to deal with difficult questions. It takes a long time when we're always stressed for time. Maybe we don't feel adequate enough to do these assessments. And how do we bring closure to those discussions? And of course, not having all the answers to those difficult questions for people. So some of the things we can do is ask open-ended questions. And Dr. May talked a little bit about this. What's important to you right now? Who do you normally turn to for help? What would be most helpful for you in this moment? And if the person is willing to answer some of these questions, get them to clarify. Can you tell me a little bit more about that? What happened the last time you were in this situation? Things like that. Get comfortable with silence, which I think is very difficult for a lot of people because silence can feel very heavy and awkward. Be present. Your time is valuable, but so is theirs. I think all of us are aware of empathy, and we all have empathy, so giving empathetic responses, if you don't have the answers, empathy obviously goes a long way. And things to avoid, closed questions. You're not going to have a very meaningful conversation if the only thing you're hearing is yes or no. Avoid distracted or distancing nonverbal behaviors, checking your watch, tapping your feet, looking like you need to leave the room. That's not going to make the person feel very safe to share these very meaningful questions. And avoiding completing a patient's sentence or thoughts. And again, that's being comfortable with that silence and allowing the time for those thoughts to come to the surface. So all clinicians have opportunities to mitigate psychosocial suffering by providing information, orienting patients to the foreign environment, acknowledging and helping to reduce their anxiety and fears, and showing compassion and establishing trust. And this doesn't matter if you're a physician, a care aide, a nurse, anybody can help facilitate this psychosocial care. So on day 2, we talked about the impact of progressive illness and mostly focused on end-stage renal disease and heart disease, and followed that trajectory that Dr. May talked about. And we also touched on grief and bereavement. Of course, grief and bereavement is a course all by itself, and I'm not going to pretend like I can smash it into 20 minutes. But I do want to just quickly touch on grief because it's such an important part of psychosocial care. So this was just a definition that I took off the internet. It's a multifaceted response to loss, particularly to the loss of someone or something that has died, to which a bond or affection was formed. So who experiences grief? The patient. The patient suffers multiple losses prior to dying. They lose their independence, their relationships, their identity. They lose their self-worth. 6 months ago, I was this person, and now I am this person, and I have lost all these things in between. Family, friends, and caregivers. Anticipatory grief is a time of mourning when someone who is terminally ill is expected to die. So people are grieving long before someone has actually even passed away. And then, of course, after death, the loss of companionship and purpose, loss of family roles, loss of love, and loss of the way things used to be. Most people will be familiar with the Kubler-Ross grief curve, and it talks about the different stages of grief. However, anyone who has ever lost anybody, and any of us that have worked in palliative care, knows that grief looks a lot more like the one on the right-hand side. The grief stages come and go multiple times. There's no time limit on it. You may revisit the same one several times, and you may never get to acceptance. It's totally individual for everybody. So day 3 was definitely the heaviest day emotionally. It was quite a jam-packed day. The first thing we talked about was relationship management and strategies when challenged by patients and families. And actually what this was about was patients with personality disorders or family members with personality disorders. And there was a huge section on how to keep yourself emotionally safe when you're working with those difficult patients. And on the hospice website, they have a brochure about relationship management. It's a really great tool, and I encourage everyone to read it. So when the personal and professional intersect, which is where I'm going to spend the most of my time for the next few minutes, and also in the afternoon of that day, we had a chance to go to 2 workshops out of those on the list there. I chose Resilience, which was about how you stay present when you're working with this heavily emotional work. And I also did the psychosocial needs of dying and bereaved children and their families. So what I didn't expect to learn so much about on this day was self-care. And the self-care theme was actually a huge overtone of the whole course, but it didn't really present itself until the 3rd day. And then looking back, you realized how much your own personal perspective weighed in on each of the presentations. So I'm just going to talk a little about the demands of our job. So we have an emotionally and physically demanding job. We work super long hours. And at home, we have families who need us. We have chores, we have obligations, and we have lots of different stressors in our lives in addition to work. But this could describe many people in many different jobs at any given time. So what's the difference with people working in healthcare? We see and experience the physical and/or emotional suffering of people around us every time we work. Sometimes we see people die. We are in physical contact with people in the very worst moments of their lives. Watching and experiencing the suffering of people on a regular basis affects us mentally, physically, spiritually. We need to practice self-care. Without self-care, we're at risk for burnout, depression, job dissatisfaction, addiction, relationship problems, being physically ill. Sometimes, though, we don't realize the amount of physical and emotional baggage we're holding on to. So I've asked Nova to volunteer this part for me. I just want to give a bit of a physical demonstration so you can see kind of what we come in contact, on a busy, stressful day at work, and what that can look like, and if we're not dealing with some of that stress, what can happen. So I'm going to get you to come and stand at the front. I won't worry too much about the slideshow for a minute. So Which way do they go? Okay. So again, I'm going to use an acute care setting for this one, just because it's relevant to some of the people here and it's where I work. So Nova, it's your Monday, and unfortunately, unlike David, I'm not considering Monday as a good thing. I'm considering Monday as the suckiest day of the week.
I don't like Mondays.
So it's your Monday, and it's the first day of your set. And during your morning report, you write out your to-do list. You're already starting to feel tense because you've been forewarned from the night shift nurse. This team is super heavy. You have 6 patients, and one of them is expected to go home today. So already, you're feeling a bit tense. Have a bag of tension.
Okay, thank you.
Looking at your patients, you have a couple of diabetics, 2 of them on a sliding scale, one of them has a complex dressing, one of them's MRSA positive. You have a patient who's an overhead lift who's going to need a CT scan at some point this morning, and the IV site blew in the night. 3 of your patients are quite physically demanding, and only 1 of your patients is completely independent of mobility. In addition, 1 of your patients is an 88-year-old male with end-stage colon cancer with meds, with a PPS of 10%. His wife of 65 years, Lucille, is at his bedside. You worked with them on your last set, and at that time, he was still sitting up in bed, joking and chatting with you. You have a good rapport with him and his wife. His name is James, but he goes by Jim. By the time you've done your initial round of vitals, glucose scans, and meds, it's already almost 10 o'clock. You've checked in on Jim and Lucille, and he did appear comfortable, but Lucille is very teary this morning and waiting for her daughters to arrive from the city. You have found very little time to spend with Lucille and Jim and so far this morning, and you're feeling quite guilty that you haven't been able to offer her more support.
Oh, do I get a bag of guilt?
Here's a bag of guilt.
Nice.
At 11, the morning rush sort of hits the fan. One of your patients receives her discharge orders, but needs all her belongings gathered because the ambulance is on the way to pick her up. The CT calls for your patient. One of your patients desperately needs to go to the bathroom and is ringing constantly. Lucille rings the call bell and tells you Jim is very restless and seems to have a lot of pain. You're starting to feel quite overwhelmed and stressed. Here's some stress. By 1300, you haven't charted anything. You haven't even finished your noon meds yet. Jim's daughters have arrived and they want to know why he doesn't have an IV. You hate trying to answer this question. You never know what to say, and it makes you feel anxious, especially when the family is so adamant. You just found out you're getting an admission. Your new patient is a gentleman with COPD. You managed to get most of the 48-6 info from his daughter, but she is extremely rude and snaps at you twice, and you find this extremely irritating. At 1500, you check on Jim and notice he is mottled, having long apneic spells, and his gaze is fixed. The mood in the room has shifted. Lucille and her daughters are tearful and quiet. Jim's daughter finds you at the nursing station and asks you to come. At 1526, you note the time of death. Lucille, who has previously been quite calm and collected, is beside herself and sobbing. You offer your condolences, give them time to say goodbye, and offer to call Stubberfields. You're feeling very sad for his wife. You're also feeling disappointed you didn't spend more time with him. You're questioning if you provided good enough care. Disappointment and sadness. Following Jim's death, you chart on all your patients, do 2 dressing changes, do all your evening meds, and your end of shift duties. But you're wondering how Lucille is doing. It's 1900 and you are exhausted. It's time to go home, but you're worried you haven't finished everything. Today it's hard to think of the good things that happened at work. And here's some fatigue to finish your day. This is obviously quite an extreme example, but this isn't that unrealistic. This happens to us all the time. And even though we have, good moments that offset this, we don't have time often to process. So at some point, you're carrying all these emotions. So what are you carrying? Tension, guilt, anxiety, irritation, sadness, disappointment, stress, and fatigue. What happens now? Luckily, some of these things you can drop and leave at work. But some of them you can't. They come home, and then inadvertently, we pass them on to our spouses, our children, and all of our other personal relationships. Or We recognize we're carrying them and we try to carry them all alone so we don't burden those around us. The problem here is when we go to work tomorrow, there's more bags waiting and you're still holding the bags from today. Ironically, all these feelings, tension, anger, frustration, sadness, stress, guilt, anxiety, mirror many of the emotions and reactions people experience while they are grieving. So this is why self-care is so important. We are mirroring the emotions of grief on a day-to-day basis. Your schedule should reflect more than the hours you spend at work. Pencil in, no, permanently marker in time for yourself every week. It doesn't matter what it is. If you're walking, cooking meals, spending time with your children, have a bath, have a massage, eat chocolate, choose activities that help you put down the baggage. Help each other. Free time is a luxury not everyone has on their days off, so check in with your colleagues in the moment. If you lose a patient, or if you're struggling with a particular patient, tell someone how you're feeling, give each other support, debrief each other, and encourage one another. If you're unable to get rid of this baggage, contact EFAP, call your physician, talk to a counselor. Your psychosocial needs are just as important as your patient's. Self-care, you need it. There's a lot of weight to the saying that you need to take care of yourself before you can take care of anyone else. And if you're coming to work carrying all of these emotions, at some point it spills over into the care you provide. You owe it to yourselves and to your patients to be in a good frame of mind. And because I care about self-care, the bags are actually filled with chocolate and you can have them at the end.
There's the chocolate.
I told you it was coming. So day 4, we talked about responding to pain and suffering, which obviously I've covered a little bit in the previous presentation. There was a long section on medical assistance in dying, which Nova's going to discuss, and then sexuality and intimacy at end of care. And the last part of day 4 was a fantastic presentation by Target Theatre Group, which is a senior citizens drama club, and they presented a play called I'm Still Here. And it was about dementia, and they do most of their presentations for long-term care facilities down the island. Like I said, there was many different people at our conference, and there was not a dry eye in the house. Like, we were all bawling at the end of this presentation. It is so good. So when they come, get your tickets, because it's worth it. Finally, on day 5, we talked about culture and many different types of culture. So the homeless population and what it's like for the dying in the streets is what the presentation was called. There was a long presentation on Indigenous perspective for health and wellness, and the last presentation was an intercultural panel. So this was many different people from different backgrounds who came and just gave personal stories about their experience with palliative care. And this is either people who have worked in palliative care, who have a life-threatening illness, or who have lost people along the way, and it was very interesting. So I'm just going to finish with a little bit about culture. What is culture? Beliefs, values, and rules and customs that are shared by a group and is used to interpret experiences and direct patterns of behavior. So obviously culture is more than just faith and religion, and you can see there on the culture wheel it includes several different facets. Why does it matter? Culture creates a sense of belonging and safety, and in our palliative care patients, that's such an important part of care. Our own culture may be immensely different from our patient and family, so we need to be self-aware and adaptable to the needs of our patients without compromising our own ethics and values. Psychosocial needs at the end of life will be more fulfilled if the person is able to practice their familiar norms within his or her own culture. So the way we visit, the way we sing, the way we eat and pray, the way we speak, the way we live, the way we die, they're all different, and none of them more right or wrong than the other. So just a couple of little fun examples of how we differ in our culture. Norms for humor. So using, to decide if humor is appropriate when you're dealing with, sick and dying people, someone might find this very funny, and some people might find it highly offensive. So just using your assessment skills to determine if that humor is appropriate. The cultures and norms around death and dying and where people choose to die. So although a lot of people on the MSP like the option, not everyone wants to die in room 414 because people know what happens in that room. I specifically had a patient who told me he did not want to go there, and it wasn't so much for himself, it was that he was worried his wife would sit and worry when is he going to die, because he was in that room. And he actually stayed in 413 until 3 days before he died, when we finally did move him to a private room. And finally, the last one, which is a super important one for me, is the cultural norms around music. And music can have a profound effect on a person depending on their culture. And we often see families playing music for their loved ones. And I think, just sort of some of the one of the associations is that soft classical music goes hand in hand with palliative care. But not everyone likes soft classical music, and I'm not sure if this music clip is going to work on here. No, it's not going to work. Darn! Anyway, I had You Have Nothing But a Hound Dog to play for you, because some people would rather have that when they die, if you're not someone that's ever listened to it and you've lived with rock and roll. So just being sort of aware of those cultural differences and how we can adjust those little tiny things for people in their last days. Once you understand and appreciate other people's cultural backgrounds, then you can connect more with them, and that's really what it's all about. So just psychosocial care in a nutshell. It's a small snapshot of what I saw in Victoria. It was a week of self-reflection and a chance to sit back and recognize what is emotionally required to do this job well. And it was a brilliant reminder that palliative care is about so much more than physical illness. And that's where I end.